you want to try this on your kid, and either like, I don't know, maybe they have a phimosis or they have like a labial effusion, you can't see the urethra, you can't, and it's like a really traumatic experience for the child. You can try this as well. He only tested this on kids younger than 1 month of age. Some other physicians did it in Canada for up to 3 months, and for like older children. And basically, up to 3 months, you'll have more than like a 50-50 chance of getting urine. Beyond 3 months, it didn't really work. I personally tried it on like 1-year-olds, and it doesn't work. So, if there's any situation where you need urine right away, especially like if you're trying to like rule out an infection, especially in younger children, 3 months and younger, this is like an option you can have. Especially if it's not like immediately urgent that you get urine right away. So like well-appearing kids with fever that you know are probably fine, but you should get a urine anyway, this might be an option that you want to try. So yeah, just some take-home points. Test everyone under 2 months, like that's just like slam dunk, just do it. Between 2 months and when they're potty trained, use the AAP criteria. So if they have a high fever, more than 2 days, if they're non-black and there's no other source of infection, definitely be suspicious of a urinary tract infection and test these children. And then if they're older than that and they're potty trained, they can give you a urine sample. They can tell you if something hurts. Just use your clinical judgment. If you have nitrites in a young child, especially like a neonate that you cath and they actually have nitrites in their urine, it's probably UTI and you should definitely treat that. First line treatment for PO cystitis is Keflex or nitro. If they have PILA, use IV ceftriaxone or Amgen in children under 1. Don't send UAs and broncholytics. And if they're dilute, if their urine is really, really dilute, you can use a lower threshold, like 3 white blood cells per high power field in the right setting. And then, you know, if you suspect a UTI and it's, you know, you're hitting all the right criteria for an infection, don't delay treatment because the parent doesn't like you to do a cath. They say it's really important. Say it can lead to renal scarring later in life, and it's something you want to avoid too. And that's it. Any questions?
Which patients do we have to refer to GU after we get these guys?
Usually none of them. If with their first UTI, they should follow up their PMD. The AAP recommends getting like an ultrasound once the infection clears, and then they can sort of take care of it beyond that. If they have like persistent hydronephrosis, like months afterwards, they might be candidates for BCUG because there might be like an anatomic thing. They might be an anatomic abnormality that's causing their infection, but you don't have to refer anyone if it's like a simple one the first time. Right.
There's a recent paper that took wet cotton swabs and pulled the child in with the body position and just rubbed their bladder with a wet cotton swab, and that works as well.
Oh, so you hold, yeah, Dr. Downey?
Yeah, just a couple of comments. The question of Adam, how do you distinguish hydronephritis in children? And how do you do it in adults? You say fever and then what? I touch your kidney and your tender there, I guess.
Sometimes.
Yeah, it's very different. How else would you say? So can cystitis give you fever? The answer is yes. But my only problem is in children who are very young, I cannot differentiate that pilot part from the cystitis part. So always has been a challenge. And again, so I call them upper UTI anyway if they are less than 5 or 6. So I never go with nitrofurantoin for that particular age group. I always start with the cephalosporin. Just my thought about that one. The second comment is that there are 4 criteria that he talked about UTI, and then I want T, and you can comment on it, is that we are checking for leukocyte esterase, we are checking for nitrites, we are checking for WBC, and we are checking for bacteria. If all 4 are negative, should I send a urine culture?
I guess you could, because something might grow.
But yeah. Is it an infection then?
Yeah, well, the point I'm trying to make is that many of us would like to do that, but less than 2. Again, there are times when you grow up and say first to pee and the culture is negative, and you saw one of the papers that says that up to 13% can have something like this, and the UA is negative, or by UA we want to send it. But generally, I, as a general rule, like people to understand that you're looking at 4 very important markers, and if all 4 of them are negative, you sending a urine culture has any value? I don't know. I generally don't send urine cultures. See, and I'm just telling you what I do in my practice here. That if all those 4 markers are less, negative in less than 2, then I'm very hesitant to send a urine culture out on that.
I think with younger children, you would send a urine culture anyway, like if they're under 2 months. You would,
Yeah.
you would probably do both. Maybe like an older, healthy-looking child, you might not. You might hold off until seeing the UA.
So the study you mentioned with the 13% or so that developed positive cultures, were there any clinical indicators afterwards? Like, did any of them end up having, did they become septic? Did they require admission?
Yeah, they didn't really talk about it in the paper. They just kind of just went, they just did like a retrospective thing, went by the culture results, and they just looked at the UA. They didn't really talk about the individual patients that ended up having UTIs, unfortunately.
And the only common thing was all of them were having severe time. So if there is a complaint.
Yeah, they all had symptoms of that needed, that like necessitated like taking a urine.
Yeah. So the outcome is already a UTI. They're just looking at what the UA showed, and then they found, oh my God, 50% and negative ways despite going up with cultures and they were symptomatic. That's why 50%.
I think just a comment to make from a practical standpoint, when we're talking about whether we're sending a culture or not, collect one, have them do a clean catch urine, you're doing that anyway, collect it and put it to the side, no one's going to fault you for ordering it. You then decide in the process not to send it, that's okay. But as you've seen, it's hard to get a kid to pee sometimes, so it can delay the process and let them stay waiting for that second window, as opposed to an adult where you're like, hey, go pee for me again. So just from a practical standpoint, draw it and put it to the side, label it. But then you can always have a discussion about whether you're going to send it.
All right, cool. Thank you.